Okay, I've been given the title Plaque Rupture is the only culprit. And I have changed it to reflect reality. Plaque rupture is the most common culprit. 10 years ago, this review was published by Dr. Masri and Dr. Fuster, the opinion leaders in this field. And already on the front page, they introduced several terms: plaque disruption, unstable plaque, vulnerable plaque, plaque rupture, high-risk plaque, plaque fissure, and on the next page, plaque erosion. I think at that time the terminology was confused. Later, the same year, the first international vulnerable plaque meeting took place in Santorini Islands. And this paper was published after the meeting in the European Heart Journal. You may say it's kind of consensus statement, also with Dr. Fuster and Masri as co-authors for this paper. It was suggested to use the terms high-risk plaque and vulnerable plaque synonymously with thrombosis-prone plaques. It's plaque with high risk of progression to thrombosis, causing the life-threatening acute coronary syndromes and rapid progression of stenosis. In fact, it was also proposed to avoid the term unstable plaque to avoid confusion with a clinical condition termed unstable angina. And here we have the definition suggested by this consensus document. 3 types of vulnerable plaque was described. Plaque with a calcified nodule. This is the least common of the 3 types of vulnerable plaque. Ruptured plaque, the most common type of vulnerable plaque, and eroded plaque in between. First focus on plaque with calcified nodule. It's a heavily calcified plaque, at that time assumed to be at high risk of progression to thrombosis. In fact, last year, the natural history of calcified nodules were described based on the Prospect trial. And in the Prospect trial, coronary lesion was followed by intracoronary imaging, including intravascular ultrasound. And it was in fact found that calcified nodules were more prevalent than previously recognized. And in fact, calcified nodules caused fewer, not more, but fewer major adverse events during a 3-year follow-up. So today we can say calcified nodules, they are very common, but they are not vulnerable. So we can eliminate one of these vulnerable plaques. So 2 remains, ruptured plaque and eroded plaque. Plaque rupture, how is it defined? You have the definition here. A plaque with deep injury, with a real defect or gap in the fibrous cap that had separated its lipid-rich atheromatous core from the flowing blood, thereby exposing the thrombogenic core of the plaque. This is the most common cause of thrombosis. So, if there is no atheromatous core, there is no fibrous cap that can rupture. So a prerequisite for plaque rupture is the presence of a necrotic core or an atheromatous core. So the production and development of a necrotic core is very important for the stability of coronary artery disease. I have here cross-section coronary artery from a fatal coronary thrombosis, the thrombus occluding the lumen, the lipid-rich necrotic core, totally devoid of supporting collagen. Collagen stains blue in this trichrome stain. Here we have a very thin fibrous cap and the rupture site here, exposing the thrombogenic necrotic core for the flowing blood and precipitating coronary thrombosis. I will show you an example here. It's a patient, a man who died after an acute heart attack. And we have the post-mortem coronary angiogram here, and we have a filling defect here proximal in the left anterior descending artery, the culprit. At autopsy, we can take the culprit out, and we can study it carefully, and we did that. So here we have a cross-section of the culprit, a cross-section with 5 millimeters interval. Here, 1, the most proximal section, and 6, the most distal section. We have wide contrast radiographic medium injected post-mortem. Here we have an intact fibrous cap. Here we have a ruptured fibrous cap. And just distal to the rupture side, we have a thrombus. Here at higher magnification, then you can study the rupture side and the thrombus in the microscope. And we have it here. Here you have the thrombus. And deeply buried here in the luminal thrombus, you can see some aromatous plaque material with cholesterol crystals that belongs in the vessel wall. It's a necrotic core. It's part of the necrotic core that had been extruded into the lumen, giving rise to aggregating platelet and fibrin formation, initiating luminal thrombosis, and clearly indicating the sequence of events. Plaque rupture proceeding immediately before platelet aggregation and occlusion by a thrombus. Recently, we reviewed the literature, and we identified 22 post-mortem studies in which the coronary thrombi has been studied very carefully to identify the type of coronary lesion beneath the thrombus. And we identified 1,847 coronary thrombi, of which 1,345 was precipitated by plaque rupture. So overall, worldwide, plaque rupture is responsible for 73% of all coronary thrombi. There is some heterogeneity in these studies, depending on the case mixed. But I think some of the heterogeneity can be explained by the difference in study population. For example, let's see the Amani study from the United States. In fact, plaque rupture was only responsible for 49% of coronary thrombi in this huge case from the United States. But you can also see that the mean age was lower than any other of the other autopsy studies. And we can also see it was medical examiner cases, so it was thrombi giving rise to sudden coronary death, in contrast to other studies where the thrombi was from cases of myocardial infarction. So if we go to Japan, China, Italy, we can see plaque rupture is much more frequent cause of coronary thrombi, but you can also see that the mean age is higher than in the Amani's case from the United States. So, is there any difference in the pathogenesis of coronary thrombi relating to ethnicity? We can see, in fact, that plaque rupture is the cause of 81% of coronary thrombi in Asia. And the lowest frequency is, in fact, reported from the United States. But it is because of this huge series from the Amani with predominantly younger persons. What about the clinical presentation? We can also see coronary plaque rupture is more frequently the cause of coronary thrombosis when the clinical presentation is acute myocardial infarction compared to sudden coronary death. Age. We can see plaque rupture is a more frequent cause of coronary thrombosis in older age group compared to younger age group. But also here again, it is dominated from the many cases from the Amani that studies younger person. Sexes, all studies agree that plaque rupture is more frequent in male than in female. 76% of coronary thrombi in male is precipitated by plaque rupture compared to 55% in women, and all agree on this association. What about cholesterol? you might expect that cholesterol should play an important role in the rupture of a plaque containing a lipid-rich necrotic core. But it's not so clear. In fact, if you go to China, a population with an average low average cholesterol level, plaque rupture is the most frequent cause of coronary thrombosis, also in China. And we have a case report here from Bill Roberts that described the pathology in a case of homozygous familial hypercholesterolemia with an extremely high cholesterol level and a case of fatal coronary artery disease. And as you say here in the introduction to the paper, the atherosclerotic plaque might be expected to consist predominantly of lipid material when plasma cholesterol is so high as you see it in homozygous familial hypercholesterolemia. But in fact, what he found, it was that dense fibrous tissue was the predominant plaque component, also in cases with high plasma cholesterol level. And only 5% of the plaque was composed of lipid-rich material. And here we have a cross-sections, left anterior descending coronary artery, and we can see that most of this is dense fibrous tissue, and there is only very little lipid-rich material. So there is no clear relation between plasma cholesterol level and plaque composition. There is no clear relationship between smoking and the mechanism of plaque of coronary thrombosis. We know that smoking promotes thrombosis, but it's not associated with any particular type of plaque composition. So we can see overall plaque rupture is responsible for 73% of coronary thrombi. Then, of course, we have another mechanism. It's thrombosis not caused by plaque rupture. It's not so frequent as thrombosis caused by plaque rupture. And it is, in fact, as said before, it is called erosion, and it's more frequent in women compared to men. In plaque erosion, the endothelium is missing, but otherwise there is not any particular features of the plaque that characterize eroded plaque with superimposed thrombosis. The amount of proteoglycans varies. There is more or less inflammation, usually less than compared to plaque rupture. These lesions are usually associated with constrictive remodeling, but not always. And there is more or less calcification, usually less compared to ruptured plaque. But in fact, there is no specific characteristic features of eroded plaque. You may say these plaques have identified themselves at high-risk vulnerable plaque by superimposed thrombus. But you cannot identify any particular feature of the plaque, and therefore no one knows how we should try to detect them, to find them by imaging. We know much more about plaque rupture and the features that characterize a ruptured plaque. So now I will talk a little bit more about plaque rupture and the features associated with ruptured plaque. We have the thrombus in the lumen. We have the rupture site here. And we have a lipid-rich necrotic core here, totally devoid of supporting collagen. The consistency of this lipid-rich core is like toothpaste. So it's easy to understand that the larger the lipid-rich core is, the more destabilized is the plaque. Also, the fibrous cap that separates the lipid-rich core from the lumen, its thickness is also important for the stability of the plaque. The thinner the fibrous cap is, the more vulnerable is the plaque, the higher risk of plaque rupture. This fibrous cap is produced by vascular smooth muscle cells. They are able to synthesize the collagen that is stained blue here in the fibrous cap. And it has been shown that the number of vascular smooth muscle cells is low at the site of plaque rupture. They have, in fact, vanished. In contrast, at the site of plaque rupture, you usually see heavy inflammation. And I'll show you another example here. It's a cross-section coronary artery from a fatal coronary thrombosis. And let's try to look at the plaque thrombus interface here with higher magnification. The thrombus in the lumen here, the necrotic core here with a consistency like toothpaste, and a thin fibrous cap here, up here. We can see that the fibrous cap is ruptured. Some of the atheromatous plaque material has been displaced into the lumen. We can see it here with cholesterol crystals. And we can also see that this thin fibrous cap is heavily infiltrated with macrophage foam cells. So there is inflammation going on at the site of plaque disruption. And we know that macrophages are able to secrete proteolytic enzymes, for example, matrix metalloproteinases, that are able to degrade all the components of the fibrous cap, predisposing it to rupture. And I think in the next presentation we will hear more about the type of inflammation. You see the fibrous cap with a different type of macrophages. We have a pro-inflammatory type of macrophages, and you have a pro-healing or anti-inflammatory type of macrophages called M2 macrophages, and a kind of battle is ongoing here between the good and the bad macrophages and the number of vascular smooth muscle cells that is responsible for healing and repair when there is damage to the fibrous cap. Usually there is very few vascular smooth muscle cells in ruptured fibrous cap. But in fact, although inflammation probably play an important role in the rupture of a thin fibrous cap, it is a misconception to say that ruptured plaque are heavily inflamed. What is heavily inflamed is this tiny structure, the thin fibrous cap. It is located next to a necrotic core. It is acellular, and there is a lot of hypocellular lipid material without inflammation or dense fibrous tissue. So the only thing that is heavily inflamed is, in fact, this tiny structure. So the cap is inflamed, not the plaque. And I think it's important to understand the challenge if you want to image a high-risk plaque and think that you should go only for inflammation, because there is, in fact, only inflammation in the tiny structure, but this inflammation is located strategically in a fibrous cap that separates a necrotic core from the lumen. So if it is degraded, it may give rise to thrombosis. The composition of the plaque needs to be permissive for plaque rupture. That is, you need to have an anatomy with a necrotic core and a thin fibrous cap, and then inflammation in the fibrous cap. Ruptured plaque are also frequently associated with expansive remodeling. It indicates that the plaque has a tendency to grow outward into the vessel wall rather than into the lumen. It has been studied by many pathologists, including Michael Davies from London. He published this paper many years ago where he described positive remodeling, it's expansive remodeling, and if you see expansive remodeling of a plaque, it is usually associated with a large lipid-rich necrotic core and high inflammation, high density of macrophages. So inflammation and necrotic core is associated with expansive remodeling, which tend to preserve the lumen. So it may be good that you try to preserve the lumen, but of course not if it occurs at the expense of a higher risk of plaque rupture and coronary thrombosis. So he concludes here, these results may explain why plaque rupture is often apparent at site with only modest luminal stenosis but marked positive remodeling. So these plaques that are high risk of rupture and thrombosis may be difficult to see on coronary angiography that only show you the lumen. And in fact, we pooled some small studies many years ago, and we showed, in fact, that in this pooled analysis, that most acute myocardial infarction originate from non-obstructive plaque, and only 14% of acute myocardial infarction originated from obstructive plaque, severe stenotic plaque. It's the lesion that you treat locally by balloons and percutaneous coronary intervention. And then it is also obvious that you cannot prevent many myocardial infarction only by treating the most severe stenotic lesion, because only a minority of myocardial infarction originate from these severely obstructive plaque. So, in fact, local treatment, PCI, in stable angina, does not reduce the risk of acute myocardial infarction, at least not substantially. And it has been shown in Chorus trial, it was shown in Berry 2 trial in type 2 diabetes, and it has recently been shown also in FAME 2 trial that local treatment of single stenotic lesion has no great preventive effect on future myocardial infarction. And now we also have a prospective observation indicating the same. It's in fact the Prospect trial that prospectively identified lesion, followed them to see what kind of lesion gave rise to clinical event. And in this study, they found, in fact, that most non-culprit lesions responsible for follow-up events were angiographically mild at baseline. Although they were mild angiographically, there was a large plaque burden detected by intravascular ultrasound, 70% plaque burden or greater. So there is, in fact, a huge lesion there. There's a big plaque, but you cannot see it by angiography. And these plaques you cannot see by angiography are characterized by expansive remodeling, huge necrotic core, and a thin fibrous cap and inflammation. So it's a dangerous lesion. Ruptured plaque are also associated with angiogenesis. And here we have to discuss also the origin of intraplaque hemorrhage. Intraplaque hemorrhage is a frequently observed change in a coronary lesion. And it is generally believed that hemorrhage into the plaque, it requires a necrotic core. Hemorrhage into the plaque may cause rapid progression of the lesion, and it is in fact a dangerous event. Also because erythrocyte contains a lot of cholesterol, so it may give rise to expansion of the necrotic core. But there is some discussion about the origin of these intraplaque hemorrhages. Nearly all agree that it may be a marker of vulnerability, and it is frequently seen in this thin cap fiber atheroma, the most common type of vulnerable plaque. And we published this paper just last month, and we described also intraplaque hemorrhage and the origin, and we have here a figure for that paper published in European Heart Journal, where you can see you have a huge intraplaque hemorrhage here. You can see in this square, you can see angiogenesis, neovascularization, and it's frequently believed that these small, new, fragile vessels may give rise to this huge intraplaque hemorrhage. But the mere presence of neovascularization does not prove that these hemorrhages originate from these fragile, low-pressure microvessels within the plaque. Another possibility is a high-pressure hemorrhage from the lumen of the artery into the plaque via a ruptured fibrous cap not revealed in this particular cross-section. For example, up here. Here the fibrous cap is extremely thin, and it might have ruptured, and you have a high pressure into the lumen, but the rupture site is not revealed in this particular cross-section. But what might indicate that, in fact, there is a rupture nearby is over here, because you can see that some of this necrotic core is missing. And how can it be missing here? It can only be missing because there is a rupture somewhere here, and the blood has washed it away distal in the microcirculation. So there is some controversies about the most common cause of intraplaque hemorrhage, but most believe intraplaque hemorrhage is a marker of high-risk plaque or plaque vulnerability. Then finally, what about calcification? There seems to be at least two patterns of calcification that might differ between a high-risk plaque and a stable plaque, giving rise to stable angina. It has been described here in this paper by intravascular ultrasound. It may be seen also by CT, but it was first described by intravascular ultrasound. It's called spotty calcification that is frequently seen in culprit lesion responsible for acute myocardial infarction. In contrast, in stable angina pectoris patients, they had the highest frequency of extensive calcification. So here you have two different patterns of calcification that may be important for the fate of an individual lesion. Spotty calcification indicating a high-risk lesion, and dense calcification that may indicate a stable lesion. But overall, calcification may also be used to identify not high-risk lesion, but high-risk patients. In fact, it has been known for a long time. It was initiated, I think, by this study, published a long time ago. It's a pathological study that was a careful examination of the coronary artery, where the amount of calcification was correlated with the amount of atherosclerosis, also called plaque burden. And it was found that the amount of calcium correlated with the overall magnitude of atherosclerotic plaque burden. And in fact, in the coronary artery, calcium is pathognomonic for atherosclerosis. You don't see Mönckeberg's medial calcification unless you have a severe chronic renal failure and often also diabetes. Otherwise, calcification in the coronary artery is pathognomonic for atherosclerosis. And in this study, the amount of calcium correlated with plaque area or plaque burden, but there was no good correlation between the amount of calcium and luminal narrowing. So the amount of calcium say nothing about coronary stenosis or flow limitation, but it tells you about the amount of atherosclerosis. And in fact, it can be used to risk assessment because it's a marker of atherosclerosis. And in this paper published just a few months ago in JAMA, several known risk markers were correlated by their ability for incremental predictive value on top of Framingham risk scoring, whether you could reclassify people here in the gray area at intermediate risk individual where the treatment is less well defined. And in this study, it was found that coronary calcium detected by CT provides superior discrimination and risk reclassification compared to with other risk markers. It was a study from the MESA, and many other studies have shown that you can use CT to detect the amount of calcification to help you reclassify people in the gray area, the intermediate risk, where treatment is less well defined. And in fact, it is also now found in the guidelines, both in the United States and in Europe. In fact, both in the United States and in Europe, it is class 2A recommendation saying it is reasonable to do and it should be considered. And the wording in the American Heart Association, American College of Cardiology preventive guidelines on computed tomography for coronary calcium, it is said, measurement of coronary artery calcification is reasonable for cardiovascular risk assessment in asymptomatic adults at intermediate risk. And in Europe, last year, it was said that computer tomography for coronary calcium should be considered for cardiovascular risk assessment in asymptomatic adults at moderate risk. It is not used frequently in Europe, but I think it is time to change this practice. If it is reasonable to do and it should be considered, why is it not done more frequently than it is, at least in Europe? So here we have the marker of a high-risk vulnerable plaque. And these markers are also potential targets for imaging if you want to detect them. But we also need to recognize that the most important thing, atherosclerosis, is a generalized arterial disease. It's a multifocal disease. There is nothing like only a single plaque or single vulnerable plaque. It is a systemic disease that needs systemic treatment. Last month, we published a paper in the European Heart Journal together with Rino Viamani at her group, where we described these different types of vulnerable plaque, And if you have interest in it, you can go to this paper and find a more detailed description of vulnerable plaque. Thank you.
Thank you very much for this comprehensive lecture about a subject which has a lot of controversy, and because of time we can have few questions. أيوة يا أحمد. لا علي حسك يا أحمد مجدي مستمعين.
I enjoyed your lecture very much. It's very important to us. Let me ask you about the theory of having severe lesions and the incidence of rupture among these patients with severe lesions, because I think this had been contradicted several times. In the past, they mentioned that only mild lesions are liable to rupture, and then last year there had been a big study that had shown that most of the patients, contrary to what we had as a concept before, patients who had plaque rupture, they had severe lesions. I mean, there is some sort of swinging between these theories. The other thing that last year I worked in the Heart Institute, and last week we saw 3 patients below 25 years who had heart attacks, and most of them they had severe lesions. So maybe the natural history in some countries are different regarding the rupture plaque and the pathogenesis of atherosclerosis.
I agree with you, there's been some confusion, and also the pathologists are the reason for some of this confusion, because many years ago we did not recognize vascular remodeling. So if you see a cross-section of a coronary artery, then you see a cross-section as you see it by intravascular ultrasound. And I told you before, by intravascular ultrasound, the lesion is severe. The plaque burden is more than 70%. So when pathologists describe plaque rupture many years ago, they describe it as a severe atherosclerosis with a narrow lumen, but the pathology cannot see the lumen whether it's compromised. And when you do this kind of correlation, what they did in the Prospect trial, you have coronary angiography followed by intravascular ultrasound, then it revealed that, well, by angiography it was difficult to see the lesion or many of the lesion, but by intravascular ultrasound you could see a severe stenosis. And I also think it explained the result of many of these trials in stable angina, where you go in with PCI and treat an individual stenotic lesion. It is so difficult to show that it improved the outcome and reduced the risk of myocardial infarction, and it makes sense if most myocardial infarction originate from asymptomatic lesion. It also explains why acute myocardial infarction or sudden death is a frequent first manifestation of coronary artery disease, because you have a lesion that is not flow limiting, giving rise to myocardial ischemia. Regarding what you see in younger people, I also think we learned something from the Prospect trial, because they did not see, of course, if you are younger compared to older, you have fewer lesions, so you don't have usually so severe atherosclerosis. But nevertheless, you may have a single lesion that is at high risk, and unfortunate, it rupture. And when the thrombus disappears again, when it lies, it may be difficult to see it, because there's not so much atherosclerosis, and the lumen is patent again. And the Prospect trial showed that every time there was an event, it was preceded by an intravascular ultrasound examination a few years or a few months before that showed at least 40% narrowing by a huge plaque. So there was not anything like myocardial infarction with normal coronary artery by intravascular ultrasound, but there was acute myocardial infarction with angiographically normal artery. So I think it's the end of the spectrum you see in younger person. They have fewer lesions, but I think the mechanism is the same.
You talked to us about the inflammation in the cap and how important that is. And my question is, how constant is inflammation in the cap? And can that be detected in vivo by measuring, for example, temperature?
Yeah.
And that has been done in aortic stenosis, where the calcific aortic valves actually had a higher temperature than the non-calcified.
Yeah, it has been explored. In fact, when the plaque rupture, there is always heavy inflammation at the rupture site. It's the reason people believe that these macrophages play an important role. So if it's rupture, there is inflammation. It has also...
Before?
Yes.
I mean, if we look for a high risk...
Yeah, so you could say, but also people dying very rapidly after their first symptoms, if they die frequently, there is already a lot of inflammation. And there is no, or very few granulocytes, it's macrophages that is responsible probably for degradation of the thin fibrous cap. People have tried to measure the temperature intracoronary by placing thermistors on the surface of the balloon. And some years ago, it was reported that the temperature of plaque responsible for acute coronary syndrome was higher than the temperature for a lesion responsible for stable angina that was higher on the normal arterial wall. But more recent study has not been able to confirm it because the flow that is passing the lesion has great influence on what you measure in the coronary artery. So in fact, I think all these tools that have been developed to measure temperature in intracoronary artery, I think they are not longer in clinical development.
One final question. Huh? Okay.
Markers have been studied and they did show some inflammation. No, my question is because I have 15 fellows in the back and you've just made my life very difficult by, some of them might have understood that it is mild coronary lesions which are causing the majority of infarctions because of that small study you referred to. But I would like to ask your opinion on that because I think there were several review articles, the last one by Dr. Fieron from Stanford in 2011, Circulation Interventions, which said that it is the very severe stenosis which are more likely to cause acute myocardial infarctions, that mild lesions, even if the plaque ruptures, most of the time they do not necessarily cause infarctions, and that the concept, because this concept has been disproven by the Courage trial, we know if we treat them, nothing happens. By all the FFR trials, mild lesions, you can leave them alone. The concept that mild lesions are dangerous has led to a plethora of unnecessary, PCI treatments for lesions which are not...
To do preventive PCI in that way. But
still not... this option has been challenged, and I think it has been put to rest. I mean, to a large extent.
Ferrans was behind the FAME2 trial, and they tried to prove it, but they stopped the trial before they had the data to show that, in fact, it reduced the risk of myocardial infarction, it reduced the risk of urgent revascularization. So, and there's the CAS data from many years ago. They showed in the LAD, the more severe the stenosis, the higher risk of thrombosis. But because you have so many more lesions that are less severe, then overall, the risk associated with these many lesions that are only less obstructing, they by far are much larger than the few stenotic lesion that may be at individual higher risk.